Hola, gracias por ver la conferencia de hoy y por esta oportunidad de hablar de cascos craneales. Mi nombre es Tiffany Graham. Estoy profesor asistente del Centro Médico Southwestern de la Universidad de Texas. He estado tratando bebés con cabezas planas durante unos 13 años. Mi español es limitado, así que continuaré la presentación en inglés. Me disculpo de antemano si hay errores de traducción en mi presentación. So today I'm going to be talking about the kind of start through finish of cranial remolding treatment. Specifically, I'm going to talk about treatment planning for the cranial remolding patient, fitting and orthosis, and the adjustments which need to be performed throughout treatment. Treatment planning always starts in creating a room that is welcoming for cranial patients. We want them to feel like they come in, it's a pediatric office, it's very friendly, have warm smiles, and we're there for that patient. It helps put the child at ease and prevent them from becoming concerned and upset during their appointment. The initial evaluation involves getting a strong patient history. Every item that the child does throughout the day, everything they play with, every toy throughout their day can have an influence on their ability to change their head shape through repositioning strategies. So we specifically want to know a history of when the flattening occurred, how long it's been there, what developmental milestones have the patient achieved. If there have been repositioning efforts in the past, which is an attempt to turn the head in different positions in order to help straighten out the flattening, and what their daily routine is. These are some examples that can affect the daily routine. Siblings can either help or encourage tummy time, or they can be involved enough that the parent feels that the infant needs to be placed in an infant positioner more often, unfortunately, and doesn't have time to do as much tummy time with them. Some infants are very tolerant of tummy time activities and others are not. In general, what I try to encourage the parents is to do as much tummy time as the infant allows, as many times and as long as possible throughout the day in order to strengthen their neck muscles and encourage not fighting the tummy time. Also, exercisers and different devices that keep the infant upright can be very helpful in keeping them off their flattening throughout the day. Other important things to note during the history of the patient is whether or not they were full term or premature. Studies we've put out through UT Southwestern have shown that infants who are premature grow like their full-term counterparts. What I mean by that is if an infant was born 4 weeks early, and I can categorize them instead of as a 4-month-old, as a 3-month-old, because it's 4 weeks younger throughout their treatment, and that is how they'll grow. They'll grow like those other 3-month-olds. I also want to know what kind of comorbidities the infant may have, because if they have any gastrointestinal issues or heart conditions or genetic syndromes, that can affect their growth rate. Cranial remolding only works by holding the areas that we don't want to grow and providing space where we do want them to grow. The child's brain development drives the changes that we see. So if we have any comorbidities that are going to affect growth, there's the possibility that the child will not see the results that we're expecting. We also really want to know, what does the parent think of the head shape? I have had parents come into my office with their child having very little asymmetry, and they think it's the worst flattening and the worst deformation they could possibly see. I have had other parents come into my office with a child that is actually with a very severe head shape, but the parents think that the head is normal or not an issue. That creates a very different sense of urgency for these families. And we need to talk through what is normal, what is abnormal, and what needs to be done about it. We also want to know a little bit about the age of onset of the flattening, who noticed it first. Oftentimes it's pediatricians that point this out, but if the parent knows this first, it may be a bigger concern to the parent than previously noted. We also want to palpate the sutures of the skull. Each suture, the metopic, the lambdoids, the sagittal, and the coronal sutures should feel either smooth or maybe with a little divot, but if they have a ridge on it that is fixed, kind of like the keel of a boat, then that could mean that there's a fusion going on. And when we're dealing with cranial remolding patients, we want to make sure that the skull is open and not fused. That's a different condition called craniosynostosis. That requires surgery. We are looking at fitting deformational head shapes, which means that an outside force acted upon the skull to create the head shape. And so we are going to use an outside force to try to correct the head shape. Measurements are also very important. This is a sample measurement sheet, but I just want to note that you should record measurements every time you see the patient, and we'll go through each of the measurements that I believe are pertinent to the treatment of deformational head shapes. The first measurement is just a circumference of the skull at the greater equator. That in particular is indicative of how much the child has grown. And so we can see this is a growth chart that's put out by the Center for Disease Control here in the United States that shows as infants are younger, they grow much faster in head circumference, and as they age, they slow down quite a bit. The ideal time for treatment to start an infant with a deformational head shape is anytime between 3 and 6 months of age, with younger having faster growth and better treatment results. You will use a cranial tape measure for this, which is just you can use a regular tape measure, but it may be difficult to keep it on their head. So I like cranial tape measures like this one made by Ortho America, because it helps keep everything in place as we're measuring the child. Calipers will be needed in order to measure the width and the length. I have an example caliper here, but the main thing is it needs to be blunt so that it doesn't poke the infant. And you're going to measure the width of the head, usually just above the ears at the widest point of the head, and the length of the head along that greater equator of the skull, which is the same place that you measured the skull circumference. That width and length creates a ratio. It's called the cephalic index, cranial index. There are multiple cranial ratio. There are multiple ways to call this number, but it is basically the width divided by the length times 100. And that number is used to gauge how narrow or wide the head is. In the center of the screen, you see a normal head shape. To the left, you see a scaphocephalic head shape, which means it's longer than it should be. And to the right, you see a brachycephalic head shape, which is wider than it should be, based on that cephalic index proportion. Asymmetry can be measured in multiple different ways. But one of the things that we like to measure is called cranial vault asymmetry. It is the difference in the diagonals of the head on either side to show how similar each side looks. Although you can use anatomical landmarks, or you can use apex to apex, mid-flattening to mid-flattening, The most common ways for us to measure in my practice is in a bird's eye view of the head. We imagine the mid-sagittal line and we go 30 degrees off center one way and the other and measure the difference between the two. We can also use 45 degrees if that is more reflective of the child's head shape based on the asymmetry that we get. There are different scales that are published that show what is a normal and abnormal range. This is one example coming from the Children's Healthcare of Atlanta Plagiocephaly Severity Scale. They use a number called Cranial Vault Asymmetry Index. It is a slightly different calculation. It is the asymmetry measurement, that cranial vault asymmetry, divided by the longer diagonal of the head, expressed as a percentage. Through that, we are able to categorize into mild, moderate, severe, and very severe categories. This is another scale published by Argenta, where it is a visual scale. They do not use measurements, but they look at the different phases of deformation. For example, for plagiocephaly, a type 1 has a flattening, in this example, in the posterior right. However, there are no secondary dysmorphic features. Type 2 has that same flattening, but now there is an ear shift. Type 3 also gets frontal shift with the ear shift, and so forth. Other measurements that can be helpful, especially as we are dealing with insurance, but in tracking facial asymmetry, is the cranial base asymmetry. That's the difference between the left and the right, from the tracheon to the subnasion. And that measurement shows how windswept the base is. You will use a facial caliper for these measurements. Orbitotriagonal depth asymmetry is also important, which is the difference in the eye placement of either side. Patient photographs are also critical for this population. Because the parents are seeing the children every single day, it is hard for them to notice small changes. When you take these photographs, you want to be on the eye level with the patient and get as strong of a view of each as possible. For example, in this first picture, you can see the curvature of the face because I am on the level of the child. You can see that the nose and the chin and the lips are all shifted. You can see a difference in the height of the eyebrows, although I've blocked out the eyes, and you can see the cranial vault shift as well. From the side views, you can see that the occipital bone is compressed, more so on the right than the left, and that the posterior cranial vault is heightened, creating a sloping of the forehead. From the top view, you can see that posterior right deformation with a little bit of frontal bossing. And from the posterior view, you can also see that cranial height difference. These pictures can be taken throughout treatment, but most importantly at the initial evaluation and at the final evaluation when the patient is ready to be discharged. That shows the parent the true progress visually that these children have made. Also, it is very important to keep in mind that our evaluation is just part of a team approach. In the United States, we are not allowed to see patients without a prescription. Therefore, a pediatrician, a plastic surgeon, a neurosurgeon, or a craniofacial specialist of some sort has already seen this patient, decided that they need a cranial remolding orthosis or potentially need a cranial remolding orthosis, and sent them to my office. In addition to the treatment that I provide, they may have a tightening of the neck, which is called torticollis. It creates a tilt and turn of the head, and it pulls the muscles out of place and also creates a preferred head position, which creates a worsened flattening. If that child is not currently undergoing physical therapy or a home stretching protocol, I need to recommend that to the parents or to the pediatrician or the referral source, because I cannot get the correction that I want without addressing the muscular asymmetry that is involved. We need to make sure we are working as part of this team, not only a healthcare team, but also a team with the family. Compliance is very important when it comes to cranial remolding orthoses, and we need to make sure that the parents are on board with this treatment or it will not work. This is an example of how to cast a patient for a cranial remolding orthosis. I will not go into detail about this. However, there is a website on the bottom that gives a very good step-by-step process of the three-part casting technique. Instead, my presentation will focus on scanning, as that is what I use in my practice. There are many different types of scanners that can be used in order to capture the head shape. In general, they are all non-contact laser data acquisition systems. Some of them use photography, some of them use lasers. They collect surface data of the head. They do not look internal to the head, therefore they do not have any radiation involved and are very low risk. Most of them are eye-safe lasers for the patients. The greatest part about this is there's no messy cleanup after a casting, and patients tend to tolerate this much better than a casting. Another big benefit, which I will talk to later, is that you can do follow-up scans. And so you can track progress as they go through treatment. This is an example of the scanner that I use in my practice and have used significantly in the past. It's the STAR scanner with cranial comparison utility. And this gives detailed measurements through a treatment report. On the left, you can see the bird's eye view of a patient throughout their treatment process, and you can see how they have changed and how their measurements have changed. Another nice comparison that can be done within cranial comparison utility is heat mapping of where growth has occurred. And that can be a good visual to parents or referral sources to keep them on board with the treatment. This is a scanner that is used by a company called Cranial Technologies. It's the DSI scanner, and it uses a three-dimensional photograph. And this is an example of their treatment report where they can show where the infant lays on the scale of mild, moderate to severe, and what is normal as well. Something to keep in mind throughout this is that nobody is perfect. Asymmetry does not mean that they need an orthosis. It's the amount of the asymmetry or the amount of the deformation that may qualify them for needing an orthosis or repositioning therapy. I want to get into now the treatment planning. We need to know if further repositioning in tummy time is likely to be effective for these patients. We need to know if there has been change in the past, if their age is such that repositioning will likely be successful, or if we need to move forward with an orthosis. In general, the literature says that prior to 4 months of age, repositioning can be a very effective form of treatment for these deformational head shapes. Greater than 6 months of age, the infants are very mobile and active and tend to not respond as well to repositioning because it is hard to keep them in a position to grow their head properly. Between 4 and 6 months of age, it depends on the severity of the infant and how active they are as to whether or not repositioning will work. We also need to keep in mind when we see the patient, if we do recommend repositioning, we need to determine how soon we want to see them back. If it's going to be in 2 weeks, 4 weeks, 6 weeks, or 8 weeks. Generally, the younger they are, the faster changes you see. So having a 6-month-old come back in 2 weeks is not likely to see any amount of change. However, having a 2-month-old come back in 2 weeks, you may see some change. A cranial molding orthosis treatment plan involves the evaluation and the scanning, and then I want to talk about the timeline that we generally have. The orthosis fitting is generally within 2 weeks, and then I start to follow up these patients on a regular basis because we want to make sure that the orthosis is contacting the head but not applying pressure, and that the family is wearing it 23 hours a day, 7 days a week. There is a break-in schedule. So usually I see the patient 1 week after they are fit to make sure that they are up to the 23 hours a day and that the child is not having any problems and the parents don't have any questions, that they are fully compliant. After that, I see them every 2 weeks for a while until they age up and are starting to slow down in growth. And then it may be every 3 weeks or every 4 weeks, depending on growth. The average treatment duration for an orthosis is 3 to 5 months. Typically, for those who have scanners, I like to scan every 6 weeks to show the parents and the referral sources, if needed, how the head shape is changing. I send the evaluation and discharge reports to the prescribing doctor to show how these infants have changed over time. And ultimately, our goal with this treatment plan is to take a severe patient, which is shown on the bottom left, and create a normal head shape, which is shown on the bottom right. Another part of the treatment plan is determining when the patients will be done or when they have the head shape that we want. So we need to be upfront with the parents to let them know what is the expected duration, if it's between 3 and 5 months, or if it's a little bit longer, a little bit shorter. I have had infants completely corrected within 6 weeks, sometimes 4, but I usually keep them in a little bit longer to make sure they maintain the correction. And I've had other infants that took 8 months. It depends on their age and how much they grow and how severe they are. More severe takes longer, older infants take longer. Are we looking at purely visual goals or are we looking at measurement goals? If you have measurement goals, you need to tell the parents, I want to get that cranial vault symmetry from a 17 millimeters to below 6 millimeters. Whatever your goal is and your criteria for discharge, let the parents know up front. We also want to think, as we're going to order this orthosis, what areas of the head do we want to hold and what areas do we want to grow? And that growth area needs to be void spaces. So here's an example of where I would want to hold and where I would want to grow for this particular patient. I want to hold, this patient is wide and flat on the posterior right, anterior left. Therefore, I want to hold the anterior right, posterior left in order to grow out the other areas where I want void space. I also notice that this infant is wide with a flattening of the central occipital bone. So I want to hold the width of the head and provide space for them to grow in the length. This is just to show you how one particular patient would be, but there are also general holding zones which every patient will have in order to prevent rotation, tipping, and falling off of the orthosis. Those 4 holding zones that every patient has is on the temporal extensions to help with rotation, and posterior to the head, the ears on the mastoid processes in order to lock it in and keep it from tipping off or popping out. If your trim lines do not encompass those areas, you will have fitting problems throughout your treatment process. In the United States, the FDA, Food and Drug Administration, controls who can fabricate orthoses. Depending on your country, it may or may not be regulated. These are the manufacturers that, or some of the manufacturers that are allowed to create orthoses within the United States. Starband is North America, Hanger Cranial Band is Hanger, Boston Band, Boston Brace, Doc Band is Cranial Technologies, and the Michigan Cranial Reshaping Orthosis is Danmar Products. The main thing in deciding which brand of orthosis to use, or if you are allowed to fabricate in-house, is that you need to know your treatment goals and pick a design that will complement your goals. Some of the options that we have, these are just all different brands of orthoses within the Starband family or within Ortho America. So just one manufacturer has all these options. The Starband generally is a plastic outside with a foam inside. The Starlight is plastic on the outside with particular points of padding. And the Starlight Pro has a different type of hinge opening and is specifically used on endoscopic surgical repair of cranial synostosis. So not with the cranial reshaping that we are doing for deformational head shapes. More design examples here. We have what are called D-trims, which basically means for the infants that have a high posterior cranial vault, you can have the orthosis extend more on top of their head to hold that and provide space in the front to grow out that slanting. You can also have what's called a holding cap, which is seen on this bottom center picture towards the left. And that holding cap is extra material designed to hold the bossed area and prevent that area from growing. You can have an oval opening, which just provides more airflow, or you can have holding caps as shown on the bottom right picture here as the anterior right and posterior left holding caps. There's also the possibility of drilling ventilation holes, as you see on this Post-Op Pro. Now, I will say that in general, if I am going to drill holes in an orthosis, I recommend only drilling them on the flattened side for the reason of the infants will tend to get a bit of window edema, and it will be bothersome to the parents to see little balls of edema on these patients if you put it in a holding zone. These are all other different types of orthoses. So just know that there are many different looks available and many different ways that these can be fabricated. When we go to fit the orthoses, you want to keep in mind that there are certain tools to use and to practice with these before you fit your first patient if you have not used them before. This is our ultimate goal, is to have clearance around the eyes, usually right at or just above the eyebrows, clearance on the ears to where it is not pressing in on them, but it is as close as possible to those ears, and clearance in the peripheral vision. So we want to make sure that the infants are able to see their entire world without being blocked by that orthosis. Some of the things we can do to pre-fit the orthosis before the patient even comes in. This is a Starband. That is the brand that I tend to use. And as they come to us from fabrication, the edges are rather sharp. And so we round out those foam edges to be more smooth, as you see in the pictures on the right, and a little bit more open. I also live in a very hot environment in Texas, and sweat is a big issue for my patients. So I like to open up the top a little bit more to allow more airflow. I will trim holding caps into the orthosis by trimming out other areas. And so this orthosis was ordered with a standard D trim, and then by trimming extra in the anterior right, I essentially created an anterior left holding cap. This is another trick. Some orthoses are difficult to open. If they are difficult to open for the parents, one of the things that can be done is you can drill a hole and create a slit to help open that orthosis. Do keep in mind though, that this does weaken the plastic and creates a bit of a plastic hinge between the ear and that drill hole. So you just want to make sure the parents aren't pulling too hard, because it will be much easier to open this way if you decide to do that. When I initially fit a patient, the trim lines typically are not my final trim lines. I need to go in and adjust it. So I will look to see, for example, on this patient, the orthosis is sitting low on his right eye and a bit higher on his left. I want to even that trim line out so that I can just barely see the eyebrows. I also want to clear his peripheral vision and clear the area around the ears. This is after my initial trimming, and I'm going to recheck everything. Right now, I am very happy with the vision in the anterior view of this orthosis, but it is still a little bit close on the ears. It is touching the top left ear, but is otherwise clear of that ear, so I would trim a little bit more on the top left. On the right, the entire posterior ear is touching, so I want to trim that back a little bit, but I want to maintain contact on my mastoid process on both sides as I do this. So this is another final check. On this one, I am very happy with the way the left ear looks and the way the eyes look. The right ear, this picture is a little bit deceptive. It is actually not touching the ears, so this will be a very good final trim line fit. Of note, this particular orthosis does not close completely. Star bands are not necessarily designed to close completely. Dock bands also do not. So you want to teach the parents to get an amount of tension in the strap. They don't want to make it so tight that it's creating a beet red mark on the forehead, but you also don't want it so loose that the orthosis slides around. I find that the adjustment to tension on a daily basis of an orthosis that does not close completely helps maintain a proper fit as the child grows and aids in not having as many fit problems as we grow and as we change the orthosis throughout treatment. I also want to check those holding zones, the temporal extensions, the mastoids, the posterior cranial vault, and my bossed areas. I will also check my void space. Sometimes you may need to manipulate your fingers in a different way or use a blunt end tool to be able to check to make sure that the orthosis is not contacting in those areas and that there is always going to be room for that child to grow. And this is an overlay of those fitting and holding zones and spatial zones. These are the tools that I use. Most of the tools on the right are grinding cones that you are accustomed to. On the left are grinding cones that are used to grind the inside foam of the plastic, inside foam of the orthosis. One is made by Autobach. It's called a round end sanding drum. The second one over is a custom-made cone out of prosthetic foam, which we shave into the shape that we want. These are much easier to get inside the orthosis in order to do the adjustments. Another thing that you will need is a heat gun or a rounded surface, especially if you have ground out all the foam in the void spaces, or if you're using an orthosis that does not have a lot of internal foam, then you may need to heat and flare the void spaces in order to allow space as that child grows. I like to use riveting bars because they are a very similar shape. If the riveting bar is not available, sometimes my vices have these ball ends to them that I can use in order to push on the orthosis. As with any foam, you want to make sure you heat the outside and you do not push and drag or it will tear the foam, but you can do pinpoint pushing of the orthosis in order to create more space and make the orthosis last longer for the child. You can also pad areas if there is not enough contact. Besides taking a heat gun and pushing in to create snug contact on the cheeks, you can also use Aliplast padding or rest-in foam padding, which is a very compressible material, in order to add contact to those areas to prevent tilting and turning. Sometimes when I order an orthosis, there is too much void space, and I may temporarily fill an area with a small rest-in pad in order to prevent excessive movement of the orthosis, which I will remove later on in the treatment process in order to create the void space for that child to grow. Again, growth adjustments are going to be only in our void space. At each visit, you want to follow-up visit as the child progresses, you want to check the void areas. Again, you can use a little blunt end instrument to go in there or your fingers. Once those areas start to get tight, if you have an orthosis with foam, you want to start using your tools to grind out that area, and you can grind all the way to the plastic eventually. I usually grind 1 to 2 millimeters at a time. Unless I have a child who is growing very rapidly, then I may grind up to 3 millimeters in these areas in order to create space for them to grow until their next appointment. I also always try to overshoot the amount of growth that I expect, because things happen with parental schedules and they may not be able to come into the next appointment, and I never want this child to run out of space to grow. The FDA has identified cranial remolding orthosis within the United States as a type 2 medical device, and one of the side effects that they have identified is that if there is not enough space for that child to grow, it can cause intracranial pressure and potential brain damage. So we always want to be doing consistent follow-up, regular follow-up with these patients to make sure that they always have room to grow. Pressure adjustments are done in the contact zones. We want to look at the child's skin and determine whether or not a pressure adjustment needs to be done. In general, the skin can be pink or red, and we need to help the parents realize what is pink and what is red. The example I like to give is if you were to cross your legs and uncross, the mark that is left behind is pink and it goes away very rapidly. That's like this example on the side of the head of the infant in the first and the second pictures, just above the ears. These marks are normal as the orthosis is contacting those areas. So when you take it off, they should be there and go away within about 20 to 30 minutes. The mark on the third picture on the far right is not normal. That is showing excessive pressure. It is a red mark that would not go away within 30 minutes. That is an area that we need to adjust the orthosis. We need to grind out that area or heat out that area in order to make sure that the child does not get a pressure ulcer in that area. One of the worst ulcers I have seen on my infants was a parent that left it on for 23 hours straight without doing any checks, and the child had an issue like the one on the far right, which wound up getting infected with MRSA, and we had to leave the orthosis off for several weeks in order for the child to heal their skin and grow their hair back. That child ultimately needed a new orthosis because we were not able to continue with the same one due to excessive growth without wearing the orthosis. So it's important to catch these skin irritations early and address them before the skin breaks down. One of the tricks that I use in order to do these adjustments is to just draw with a pen the adjustments, the areas that I want to occur. So for example, in this picture, I am using lines in the void space in order to create a general space that I want to grind in, and more of a star or hash marks in the areas of pressure for the child. I will grind the void space probably about 3 millimeters in this case, because it was a fast-growing child. However, the areas of pressure, my initial fit, I will only grind off the pin marks, which is about the equivalent of 1 millimeter depth into the foam. I will then put the orthosis back on the child, have them sit for a few minutes, take it off and see if there is still redness. If there is still redness, then I may grind one more time. I try not to over adjust the areas for pressure, because if I do, the child will start growing in those areas, which generally are areas where we do not want them to grow and would hurt their head shape. I will overgrind quite a bit in the areas of void space because I want to direct that child's growth in those areas. Another thing to keep in mind, at every follow-up visit, you want to check to make sure the orthosis is fitting properly. There should be contact in the cheeks and the mastoids so it's not tipping, turning, or popping off by itself. We want to check the circumferential growth of the patient with that cranial tape measure to know how quickly they're growing and how much space we need to create, and check those void spaces again for that growth. If you have a scanner available, doing follow-up scans can be very helpful to note whether or not the patient is being compliant and how they are changing. In the scan on the left, the child has been wearing this orthosis 23 hours a day, 7 days a week, and you can see that there is essentially no growth in the progressive scans in the anterior left or the posterior right, with nice growth in the flattened zone in the anterior right and the posterior left in progressive scans. And this child's head shape is correcting very nicely. In the second scan on the right, you can see that the child overlay scan, the first scan to the second scan, is globally larger. The areas that we would like to hold on this child are going to be right above the ears, the anterior left and the posterior right. Although this child's measurements were improving and the head shape was looking better, we were losing some of the correction that we could have gotten if they had been wearing it 23 hours a day because of that excessive growth in the width. This child also had red marks above the ears consistently at almost every appointment, and that's because this growth was occurring. If the child had been wearing it 23 hours a day, 7 days a week, then they likely would not have had as significant of redness, or maybe no redness at all, and we would have been finished with treatment much faster because we would have directed that growth. Thank you so much for this opportunity to present, and I hope this is helpful for you to move forward in your practice.